Good morning, everyone. Just see this gate and keep in your mind what it is for now. So this is about a 24-year-old man who is not working for the past 1 month because of psychiatric disorder. He is actually from Vellore. He presented with complaints of weakness of upper and lower limb for the past 4 days. So the history of presenting illness was he was under treatment in Bahayam for antidepressant induced maniac fits. And on 4th of March, he had a psychotic episode. So for that, he was taken to Bahayam, where he was given some injectable drug, and then he became drowsy after that. So the next morning, on 5th of March, after waking up, he was a little drowsy and he had a fall, and he sustained injury over the left shin. After this, his parents and his relatives noticed weakness of the left upper and the lower limb. So for past 3 days, they were at home. On 9th only, they presented to our ED. So since the fall, there was no progression of symptoms. He was able to perceive hot and cold and clothes, and there was no paresthesia or numbness. So there was no bowel or bladder symptoms. There was no change in mental status. There was no loss of consciousness during the fall. And there was no fever, no seizures, no blurring of vision, no headache, or no neck stiffness. So past history-wise, there was no similar complaints in the past and no other comorbidities apart from the psychiatric. And there was no previous TAA also. So personal history-wise, he's not a smoker, not an alcoholic, and there was no drug abuse. And he had normal bowel and bladder habit. So on examination, he was conscious and alert, but not much cooperative, as he had a psychiatric episode recently and he was on drugs. So there was no malar cyanosis, clubbing, or lymphadenopathy. His pulse rate was 90 per minute. All the peripheral pulses were felt. And respiratory rate was 18 per minute, BP of 120 by 80. And systemic examination wise, CVS, RS, and abdomen, no abnormalities were detected. Coming to CNS, pupils were 3 millimeter reacting to light, and extraocular movements were normal, and he did not have any nystagmus. Facial sensation was normal, no facial palsy, uvula was in the midline, and gag was present. So coming to motor examination, pulse was grossly normal, tone right side was normal, left upper and lower limb was normal, power in the left side, the power was, right side it was 5 by 5, and left shoulder, abduction, adduction, flexion, extension, everything it was 5 by 5. Left elbow flexion was 5 by 5, extension was 4 plus by 5. And left wrist flexion was 5 by 5 and extension was 3 by 5. Left hip abduction, adduction, flexion, extension, external rotation, internal rotation was 4 plus by 5. Left knee extension was 4 minus by 5 and flexion was 4 plus by 5. Left ankle dorsiflexion was only 2 by 5 and plantar flexion was 3 by 5. Left extensor hallucis longus and dorsiflexion was 2 by 5 and plantar flexion was 3 by 5. Left hand grip was weak. So reflexes on the left knee jerk, left knee jerk was 3 plus, other all were 2 plus. Abdominal reflex was lost in the left. And bilateral plantars were mute. So sensory is grossly normal, no cerebellar signs and no meningeal signs. Gait was as seen in the video. So with this clinical presentation, and our thought process was initially it was like a left-sided hemiparesis with localizing it to right cortex or subcortex. Pathology would be like infarct or bleed, and etiology would be like CVA. So we went ahead with MRI stroke protocol, and to our surprise, it was completely normal. So then he's having UMN symptoms in the left side, hemiparesis is there. So what is it if it is not a stroke? So then we went ahead with a detailed examination, and by this time we were able to optimize his psychiatric medications also. Like we were able to optimize with the help of psychiatrists, and he was becoming more cooperative also. And by this time his disease was also progressing. Like his tone has increased in both the left upper and the lower limb, and reflexes, all the deep tendon reflexes in the left became 3+ by now. And pain sensation was reduced from the level of T1 in the right side. And joint position was lost in the left interphalangeal joint of the left lower limb. And fine touch was reduced in the left side C6, 7, and 8 dermatomes. So he was having involvement of three tracts, like the corticospinal tract in the left, and that's why he was having weakness in the left side, and posterior column in the left, as his vibration sense was reduced in the left, and spinothalamic tract involvement in the right side, as his pain was reduced in the right. So the gait which we saw in the first slide was a high stepping gait in the left side, and there was no spinal tenderness. So with this, my localization was motor level of C6, sensory to T1, reflexes above C5, and vertebral level was above C5. So we were able to localize it to the cord, lower cervical cord, and we went ahead with MRI cervical spine with whole spine screening. So our clinical diagnosis now was lower cervical myelopathy, hemicord syndrome. So this was his MRI. So it was reported like at C4, C5 level, there is a posterior disc osteophyte complex causing significant compression of the cervical cord associated with the cord signal changes. So compression was more along the left side. So you would see the compression at the C4, C5 levels. So this is a normal transverse section of the spinal cord. So the posterior column, which carries the joint position, sense, vibration, and pressure, is at the posterior one, like in the dorsal side, and the spinothalamic tract is on the lateral spinothalamic tract, which is carrying the pain and temperature. It's on the lateral side, and the corticospinal tract is also on the is also located laterally.
Can you point that out on the distinct picture?
It's not coming here. So hemicord syndrome, also called as a Brown-Sequard syndrome. So there is ipsilateral weakness with the corticospinal tract involvement, and ipsilateral loss of joint position and vibration sense because of the involvement of posterior column, and contralateral involvement of the pain and temperature sensor, 1 or 2 levels below the lesions. So there will be segmental signs like radicular pain, muscle atrophy, or loss of deep tendon reflex. It's also seen unilaterally. So most of the time, partial forms are more common than fully developed syndrome. So from this, my take home was not all hemiparesis or stroke. And if there is any discrepancy in history examination and radiological finding, we need to do a detailed clinical examination so that we will be able to localize the lesion better. And this is an uncommon etiology of cervical myelopathy presenting like a stroke. Thank you.
Evangelin, will you just go back to your clinical findings just for a minute? So when you say the levels, so what do you mean by that level? So you said that say a spinal level of T1, sensory level of T1. So what does that mean?
So from that level, he was able to on the right side, there was a decreased sensation compared to the right side.
Okay,
So
then below T1, T2, T3, what happens?
his pain sensation was from that onwards, it's like in all the dermatomes, it was reduced. Sir.
So from T1 all the way to,
Yes, sir.
and the sacral sensations?
Everything, sir. It was
So
reduced.
he had decreased sacral sensations
On
his
the
side.
right side, sir.
Okay. And did he have any bowel bladder involvement?
Subjectively, he was not having any bowel bladder symptoms, but we did a post residual.
Did he do a rectal examination? What did that show?
No, sir.
So how do you explain the upper limb sensory loss?
So he was actually having bilateral ones, right? His this touch was actually reduced on the left side C6, C7, and C8. Sir. Actually, his the compressive symptoms were on both sides, but more pronounced towards the left side, sir.
Okay, so let's just go back a little bit. So initial diagnosis was a stroke.
Yes,
so
sir.
what are the features which are not fitting into a stroke in this patient?
What will differentiate a cord from a intravenous cord? Like it's the stroke.
His initially his tone was normal, sir.
Heavy paresis. What will differentiate a cord from intracranial pathology? What will be affected if there is like an intracranial vascular level that you're not seeing at all here?
Cranial nerves can be involved, sir, but there is no cranial nerve involvement.
So in an upper cord, what are the cranial nerves that can be involved?
9 trigeminal nerve involvement can be there sensory, and 10, 11, 12 can be there.
That's your example.
Spinal axis is also in ICBG and
So if you're not finding biceps is obviously you said it is
Exaggerated.
8 plus. What else can you check to see is it higher or is it because you said C5 above?
Pectorals. Pectoral can be checked, ma'am. Deltoid
Deltoid.
can be checked.
What else do you check?
and trapezius also.
You can actually do jerks on your deltoid.
Deltoid, yes.
Yes. And you can see if that is exaggerated. Especially in the C5 when you would have deltoid loss. But your biceps might be exaggerated. Remember at that level you have it lost. Okay. So you don't stop it just when you are an MD student, you just don't stop it. Biceps, triceps.
Yeah, deltoid we checked the mind.
Report your deltoid, do your triceps.
That was not normal. Deltoid was normal actually.
Okay, for the